It's a great pleasure to open this debate of the Health Innovation Forum 2020 and our digital edition about healthcare in Spain and its model of education, training, and professional education. We have the honor of listening to Professor Montserrat Sánchez from the University of Lleida. Professor Montserrat Sánchez is professor at the School of Nursing and Physical Therapy at Lleida University, and she's a specialist in qualitative research and public health policies from the Nursing School of Bloomberg in University of Toronto. We are also going to have Dr. André Volschan from Pró-Cardíaco Hospital, and Dr. André is a medical doctor, a doctor of medicine from the University of Rio de Janeiro, and he's currently the medical coordinator of the emergency unit of Pró-Cardíaco Hospital in the city of Rio de Janeiro. He has wide experience in medicine with emphasis on emergency and cardiology. We also have the honor of listening to Dr. Adriana Aguiar from Oswaldo Cruz Foundation. She's coordinator of preceptorship and residence programs in Brazil and Spain, education, research, and management. Adriana Aguiar is a doctor. She's a researcher of communication and healthcare at Fiocruz. It's an honor to have you all here. Each one of the speakers will have 10 minutes to make your presentations, and we are going to start listening to Professor Montserrat Sánchez. And when we are 2 minutes before the end, I'm going to tell that to you. Thank you very much for your presence here today and everyone who's watching us. Hello. Again, we are back to the presentation. So as I said, thank you very much. To me, it's a great honor on behalf of the Department of Health of Catalunya to be today, this afternoon, with you to make this presentation that I have prepared to share with you so that you can understand a little bit more about the healthcare model that we adopt in Catalonia, in Spain. What is the education, capacity building, and professional education? And certainly on behalf of healthcare professionals and the Department of Healthcare that has invited us to share our model with you. Okay, so here we have a table of contents and introduction. So there is a little table of contents. There's a brief introduction, and then we'll be talking about demography in healthcare professions, and lastly, the education of new professionals. So this is the demographic situation, the evolution of the population in Catalonia. You can see the graphs. So the population is going to age, and we're going to have fewer children with a reduction of births, as well as the population is going to increase. We are going to have higher life expectancy. So we are going to have more chronic health problems. We estimate that 37% of the population of 15 years of age or older will have some health problem, and the prevalence is going to include as we grow. In addition, the prevalence of deficiencies follows the same standard and is bigger among women, and it increases as age goes up. In turn, the population is going to have more social needs, and therefore will need to respond to the needs of a population that will be even more frail. So, considering the whole scenario and to understand a little bit more about this educational system within the healthcare, so we should go back approximately 16 years when children in secondary education and they decided whether they wanted to continue having an education that they can go to any university degree, or if they wanted to have professional education, a more professional, so they can choose different career paths. So they could choose different areas in the healthcare careers. So, such as sanitary or health emergencies, pharmacy, and even different kinds of certificates, such as pathology, pathetic, health management, oral hygiene, imaging, nuclear medicine, clinical, laboratory, biomedical, orthesis and support products, dental prosthesis, and radiation therapy and dosimetry. So these careers give you a certificate that you are considered a technician in these areas. And here we have the demography of the healthcare careers. So this is an overview of healthcare careers of these healthcare workers. So this is the pyramid. And then you can see all the healthcare careers. So here at university level of people who have graduated, and these are graduates. So people who already have a degree, they're actively working. As you can see, the basis are nurses with people a degree nurse, almost 45,000 people graduating in nursing, and then doctors, and then fewer and fewer of other healthcare professionals, such as pharmacy, physical therapy, dentistry, psychology, nutrition, podology, podiatrists, dental prostheses, and so on and so forth. And on this slide, you can see the evolution from 2012 to 2017. As you can see, the evolution is quite stable and with a trend. In groups such as physical therapists, for example, we try to integrate them more into the public healthcare system, although they have a private bias. And these groups are the groups of pharmacists that have increased the most. And with that regard, as you can see on the evolution of this chart, once again, nurses are the ones that account for the highest increase in volume number of workers of all healthcare careers. In all careers, there is a balance, but there is a trend for growth which corresponds to the levels of dependency in the career too. And then on the next slide. But here on this chart, you can see a little bit which are the ages per profession. And then you can see the number of healthcare workers here. For example, you can see the ages, and you can see their ages, and we will need a large number of professionals to deal with all the retirements. And then nursing, such as occupational therapy, physical therapy, and they are younger workers working in these areas or in these careers. And on the next slide, we can see the distribution of healthcare workers per sex. So in healthcare workers per sex, we can see that there has been a significant trend in the last years to have an increase in the number of women in these careers, and this applies to approximately to any healthcare career except for pharmacy. So we have a significant number of women in all these careers that are healthcare careers. And then we can see the next slide, which is about the distribution of healthcare careers according to nationality. And on the screen, you can also see the distribution depending on the nationality, as I said before. So with 17 workers are registered, come from overseas. They're not Spanish, they're foreign. So 2% correspond to countries that are not part of the European Union, especially Peru, Colombia, Venezuela, Argentina, and Cuba, non-EU countries. And from the EU, we have Italy, Portugal, Romania, Germany, France. Also because of geographic closeness. And there are some workers whose origin we don't know to work in Spain. And now we have the next slide. So with regard to the distribution of healthcare workers depending on healthcare line, so 60% of healthcare workers are concentrated in hospital and critical care, and 27 in primary care, primary health care. So then we have fewer professionals in social care and mental health, 3.64%.
Siguiente, por favor. En cuanto a los grados universitarios de profesiones sanitarias,
in terms of university training, I'm going to show you our education here because we have new professionals. Next slide. Here we have the graduation of different professions. In 2011-2012, there was a decrease, a somewhat sudden decrease for graduations in nursing. Not because people decided not to be nurses anymore, but there was a restructuring of the study plans. So all levels and training started having 4 years, except for medicine, which still had 6 years before specialization. There is a slight increase in the number of graduation in all those healthcare-related professions. Here we can see the different supply, what is provided by different universities, and also those participants and those that drop out. In physical therapy, nursing, speech therapy, we have maintained the same level or had some slight increase, whereas those in blue, in some specific areas such as speech therapy, in addition to many students join the course, many drop out before completing. Here, for some additional training courses, we have a very stable presentation, but for nutrition, dietetics, we've had many students join the course and a lot of dropouts. And this is transferred into a higher rate of dropout. Here we can see the production of different options, especially between 2013 and 2015. Reason why there is the current shortage of nurses, because here we have psychology, also occupational therapy, which present a higher rate of dropout. Here we have a distribution by gender according to courses and the different graduations, reproducing what we've just said, but we can see that it's much more marked here because the great majority of students in the healthcare area at university level are women. And the chart we show you of the professionals in pharmacy predominantly used to be a profession of men, but in students it's exactly the opposite. Now I'm going to tell you about specialized training for healthcare. And this is at the specialization level. After graduation, they'll go into graduate studies. Next one, please. Here we have the distribution of specialization in Catalonia. As you can see, the great majority are specialization training for physicians. It's followed by 5 specialties for nursing and much fewer for pharmacy, psychologists, the one that we have clinical specialty, and then there are 6 multidisciplinary specialties or specializations where we have biologists, pharmacists, physicists, and chemistries. There are some university hospitals, also family and community care centers, and occupational medicine. Let's say a course that we are going to offer in Catalonia includes nearly 5,000 resident physicians, for example. Next one. Here we have the distribution of the whole map of Catalonia, because the appeal that the city of Barcelona has most are in hospital units in the city of Barcelona. All the others are distributed throughout the whole territory. In terms of distribution, in order to have something better distributed of all residents that are going to go to hospitals to be specialty, we should first analyze the needs. How many graduations would be required within 6 and 15 years? Once we have a new change in generation, what are the needs identified according to our healthcare plan? Because there are some specialties which are more strategic. For example, allergologists. Do we have enough allergists to care for our population? Not quite. So, considering our current levels of contamination, this is a specialty that it would be great if we could have more professionals. Likewise, we have a different offer of seats in all different regions. Once we have access to the information, we divide the territories according to quality criteria. There are some indicators, over 1,000 indicators to assess the different centers and also different territories. We divide them in different levels, so first, second, and third tier, so to speak, so that all residents are distributed not only in the metropolitan area of Barcelona. This would force people to go away from the main centers. This is the progression of specialties. The last 2 years, 2019 and 2020, that you cannot see here, we have achieved a historical record of number of resident students, and we have already overcome the numbers of 2010, when there was a significant, followed by a significant drop, as you can see in the chart, especially because of the economic recession we have experienced and because of reductions in healthcare. Next. Thank you very much for your attention, and I'll be glad to entertain your questions. Thank you. Thank you very much, Professor Montserrat, for your very complete and interesting presentation of the situation in Catalonia. Let me now invite our next speaker, André Volschan of Hospital Pró-Cardíaco. You have 10 minutes for your presentation. Thank you very much.
Muito obrigado, professora Denise. Boa tarde a todos.
Thank you very much. Thank you for the invitation by Forum Innovation and Health, coordinated by Josie Aguiar. Thank you for the opportunity to be part of this panel. Thank you very much for your excellent presentation. And I have here with us Denise Carvalho and Professor Aguiar. For 20 years, I was coordinator of the emergency unit of Hospital Pró-Cardíaco, but today I'm the coordinator of research and study. Congratulations on your excellent presentation. The Spanish system is one of the main highlights of healthcare systems in the world, and we can certainly learn a lot from your Spanish system. Your presentation did bring about some interesting points, not only concerning distribution of gender and age, but also something which is interesting because it's very rational, which is the distribution of specificities according to regional needs. And it certainly adds value to the care in a very significant way. I would like to bring some points for thought, which I think is important, correlating the Brazilian and the Spanish system. Despite our socioeconomic differences and the impact on education, I would like to understand education and training as different things, but still understanding it as something, education as something bigger and something more humanistic in the training of professionals. And this is how I think we should move on in our system and in healthcare at large. We have to understand training and how we should be prepared to these changes that are being brought about and will be faster and faster, so that we can be constantly sustainable. In terms of higher education, normally the professions tend to shape the curriculum. There was a document of the Ministry of Education here in 2014, focusing not only on the new metrics, new way of learning, but also competence. How competences can be better explored. So competence as a set of knowledge, skills, and behaviors, and not only the technique, which seems to be key, but also some additional competences that impact the training of healthcare professionals. Healthcare system is designed so much that we migrate from the classical model of training to a conception of competence aligned not only with the need of productivity, competitiveness, flexibility, but also professional multiple tasks, which seem to be really necessary. This is really important, especially in terms of non-technical competences, so that we can serve not only patients, family members, but also society, academy, healthcare, once again, bringing about aspects that should be constantly emphasized from a multi- and transdisciplinary fashion, because there is no room for solitary attempts to solve problems. And this is something that is based on clinical results showing that this transdisciplinary action really produces better results. In general, it is going to expect a lot of our focus in terms of communication, collaboration, ethics, moving towards a model in which professionals can really finish their graduation with a new mindset, a mindset in which critical analysis really provides them this active role of changes, which is something really necessary for the system, so that we can have better results, so that patients can have better experiences, and by doing that, we can effectively confirm the value of health that involves at least these two issues. Cost, of course, should also be a source of attention, but primarily considering the most appropriate practices, practices related with evidence-based medicine, respecting ethical principles, and adding efficiency to our practices. We really need to encourage evidence-based practices, and we also need to realize that the cost of health has to be taken into consideration because resources are finite. Finally, I would like to talk about technological incorporation. During the pandemic, this is something that has meant a great breakthrough for education. But it should be seen, perceived as a resource and not as a solution. We should provide it with the right space so that it's not going to replace problems. New technology, incorporation of technology is not going to solve and put an end to all our problems. And this is another knowledge gap some of us have. Professors, tutors, they are not really prepared to deal with the new leap for demand in technology. And this is something that we all have to face. Finally, I think technology is really changing nature and the roles of work, and we really have to change our behaviors. To close, let me share with you my thoughts on it. Physicians should know about how to preserve health, but also be co-responsible and use technology wisely, smartly. People who can provide specialized care in their area of expertise, capable of having a broad understanding of medicine in terms of history and capacity, someone with a social responsibility, social commitment impacting the healthcare system so that we can generate some kind of change. And finally, integrating education to research and healthcare it's a key step for the whole system to succeed and for all of us to offer what we want to offer, which is the best support with sustainability to all patients. Thank you very much.
Thank you very much, Dr. André, for your excellent talk. And we are surely going to have an excellent debate later on. Now we are going to listen to Dr. Andrea Aguiar, and then we are going to hear to Professor Montserrat Sánchez. Dr. Aguiar, please, it's a great honor to have you here. Good afternoon. I'm very happy to be here on such a distinguished fellow panelists with Dr. André, Aguiar, and Denise. And I would like to say that since 2011, I have studying the education of residents in Spain, and I identify many important parallels between the Spanish and the Brazilian systems, so that I really praise the Organization of Health Innovation Forum to include this panel with this theme. And I cannot fail to say that we have a book that was the result of the research that was funded by the Pan American Health Organization, which tells a little bit of this history and the parallels between Spain and Brazil in education of residents. And this is available on the internet at Fiocruz page. All you have to do is to type preceptors and Fiocruz, and then you're going to see in the book available in Portuguese and in Spanish. So I think that on this book, we talk about how the Spanish models of regulation and governance of specialized education and how precious they are to us in Brazil. In organizational development of the national healthcare system and on professional education as a whole. Brazil and Spain have a certain degree of separation between undergraduate and specialization education and under the format of residency. And the residency is the responsibility of the healthcare system, of the autonomous units, which are equivalent to Brazilian states, which have some similarities with Brazil. and they are centrally regulated, and it's very interesting, and I would like to highlight, and it would be very good if Professor Montserrat could comment on that. The law of healthcare professions, and we're really envious of that for us here working on healthcare education here in Brazil. And here in Brazil, we have in one of the chapters of the book addresses specifically the regulatory and legal. We have a plethora of different instances regulating that, but in Spain, they came to a degree of political and institutional agreement that provides a governance capacity that is very interesting. And here I'm talking specifically about residency programs with the national specialty commissions, all the agreements that are regular and that you have about the selection process for residents that is unified, about accreditation of healthcare facilities to offer residency, and also the advance of a reflection about something that you call educational continuum, going from the undergraduate course, going through specialization, and going through continuing education processes that are essential to assure the quality of healthcare work. So there are many obligations in the health systems and the sanitary or healthcare professionals in order to keep a care quality that is essential considering all the changes that are predictable in the offer of healthcare services. I have taken my postdoc in 2011, and ever since we were discussing this in International Health Department. And then afterwards, I saw in more detail the work of the preceptorship work and the structures that they call faculty units that are responsible for offering residency programs. And I enjoyed it very much, and I really praise the Spanish because they deal with their differences in a harmonious, sometimes it's more harmonious and sometimes it's less harmonious, but during the time of democratization of the Spanish state, you've been capable of keeping a dialogue. And the issues such as the medical specialties in the offer of residency and a certification, as it is in the Brazilian case, as we have many specialists in the residency program, and this generates some conflict that is still significant in Brazil. I think that in terms of us defining and talking about medicine, even though over there and here too, well, we have residents of other professions, but we can define a significant role for specialties and the societies in understanding and reviewing professional education, but creating a very highly respected residency program that leads to there being no questioning about the unified decisions on education, such as the single national test, which is a very interesting mechanism to avoid favoring people and therefore to overcome problems in education that may happen. And we imagine that it could happen there too. I think, and what I would like to say in terms of provocation, in terms of us beginning a discussion, is saying this. So Professor Montserrat, with her beautiful work, Catalunya is an autonomous community with very intense debate, as we know, and this is beautiful. The Spanish democracy is characterized by reflection and participation and citizenship, and we see here what happens in Catalonia, and we're very hopeful that whatever happens is for the best for Catalonia people. So we hope that you may come to an agreement with other Spanish, but I shouldn't say anything about that because I should not meddle into foreign politics. Thank you very much for your participation.
Muito obrigada, doutora Adriana. Realmente debate muito
Thank you, Dr. Adriana. Very interesting discussion. And I am going to try to make my input as well, sharing with you the experience of the Federal University of Rio de Janeiro very briefly. And then I'll have to be excused, and I would like to thank André Volschan, who's going to remain and speak after me. In the Federal University of Rio de Janeiro, we have a huge challenge, similarly to all other universities, where we have very strong healthcare training and a very large department. We have all the courses that Professor Montserrat mentioned in her presentation, so higher education courses. And it's interesting to note that in Spain, there has been a reduction in the duration of courses, reducing to 4 years, whereas in Brazil we are moving towards a different option. We have expanded to 5 years. Medical school, still 6 years. In the 90s, in the beginning of the years 2000, the course of pharmacy in my university, someone would become a pharmacist after 3.5 years of training, and they could move on in specialization as a biochemical pharmacist or a food pharmacist for 1.5 years more, so completing 5 years. It was an interesting model that I used to really advocate for. But in recent years, we have adopted one single model of training with 5 years to all. I have a critical opinion about it. I think Spain is right in its decision. If you can train good professionals after 4 years, just do it, absolutely, because we want professionals to be part of the workplace, especially a country such as Brazil, where we have socioeconomic problems. Having a higher education diploma makes them have more possibilities, improving not only their lives, having a job, but also sometimes improving the lives of the whole family. Having a much longer training is not a decision that really makes sense to me. In terms of medical school, we had an experience of 20 years in my university, which is to train a researcher physician. It's a program based on the University of Columbia in the US. It's MD, PhD. Since 2001, we started training the first physicians who are MD, PhD. They start their PhD during graduation, such as the case in Colombia since the 60s, and then they can have their PhD thesis up to 2 years after their graduation as physician. Some can finish their medical residency at the same time, others cannot. Most finish their PhD thesis and only later go into a medical residency program, which conveys specialty to physicians. The program started in the Federal University of Rio, in traditional universities such as Unicamp, but it's not in the University of São Paulo yet. It's a very successful program. It has been training excellent medical researchers. I believe there is going to be more integration between graduate studies and undergraduate studies, especially for professionals who really want to remain in the academia, generating knowledge and participating in generation of knowledge. But this is something for a small group of participants only. Most will go into clinical care only and are not going to dedicate to research. Finally, I would like to speak about the use of technology for education. We have remote education since June being provided in our university. We got adapted because there were few courses that used virtual platforms for on-site training, just few courses really. We have all theoretical disciplines now, but in healthcare, you cannot have a professional without having an on-site activity, a hands-on activity. And this is our main challenge. I would like to hear from Professor Montserrat about telehealth, if it is provided, how it's done, at least in Catalonia. We know that in Brazil, the level of use is very heterogeneous. Now, during the pandemic, the state of Minas Gerais was an example in primary care, reducing significantly the visit of patients who were possibly infected by coronavirus to healthcare units. So they were supported by telemedicine. And so these were my comments. And what are the challenges that we all face? And there are many challenges, not only the fact that we are remote, as Dr. André pointed out, but also how to train someone who's going to get adapted to the reality of upcoming decades. Artificial intelligence is here. Diagnosis through platforms will change completely our own professions. We still do not know what is going to be the impact of the use of artificial intelligence in the area of health, in all the different areas. For diagnosis, this is somewhat clear, but for treatment, we still do not know how to understand that. Thank you all very much. It's been an honor. I would like to thank our coordinator, Josie Vilar, for the invitation to be here with you and listen to your 3 excellent presentations. I've learned a lot. I'm going to stay here. We are going to be here. We still have got 10 minutes. Thank you. Thank you, Denise, for your comments. Always very enriching. So let me go back to Professor Montserrat to make her comments about what Professor Adriana and Denise have just said. Thank you very much. Thank you very much for the comments. In my country, Catalonia, I'm going to make some comments about some of the issues that were made. I'm going to start with Dr. André, who talked about the importance of transversal multidisciplinary competences. And for some years, we've been performing a number of courses shared with all residents in Catalonia. There was an emptiness in training, especially some values, some intangible elements, things which were more difficult to evaluate. But they were useful so that all resident physicians could have a common curriculum of all competences that would be required. Another thing that you comment about information technology and communication, and also emphasizing the remote training that we've just heard. Technology has been fully integrated in our daily practice, and I'm sure they are here to stay. It provides remote populations to have access to services which would not be available otherwise. At the same time, in all relations related with competence and training of healthcare professionals, it's very difficult to expect to have that done just remotely. We would have to have a hybrid model. So patient safety, assessment of competence such as empathy, for example, interactions. And I think that 100% virtual universities, I'm not sure they have tried to provide courses of healthcare professions such as nursing and medicine, which are really applied courses that need hands-on. So I don't think we have ever approved a program of such characteristics. So in addition to clinical practices, and of course it can all be, we can have the theory presented virtually, and then you would have a practical hands-on session. Just correlating the gap between theory and practice, something that we've been trying to address for so many years. In terms of research, as I've heard from André and Adriana, we try to investigate, we try to include as part of the competences research skills. But I really enjoy the model of the University of Columbia, where you have graduate studies and PhD studies, those that would be interested in maintaining their research efforts. Here in the residency program, we've tried to influence that. They needed some continuous training and all that, but what happened is that what we see now in general is that we don't know how we can integrate for sure investigative competences and something for real, not only on paper. So that here, as well as in other countries, once a resident has finished graduation, can also apply for the PhD, such as the case in other contexts. Here, the clinical practice and the bedside care tends to be more important than other aspects of investigation. And this is something that can be improved, and of course we should focus on it in the near future. Only with evidence-based practice we can for sure improve the results of patients, which is something crystal clear. Concerning telemedicine, implementation is also very uneven, even though in Catalonia we do have an advantage to point out. We have a very strong industry of technology in our region. There are many high technology companies, and as such, we tend to be even more competitive because we can run projects with new devices, new applications, etc. And it does give us a minor advantage. The main challenge concerns issues related to digital literacy, because our population is somewhat aged, and in some territories we have them widely distributed in the territory. So providing education is something very difficult. So sometimes even older people that never thought they would be able to use some tools have been doing it and quite well. So based on courses provided by social centers in different regions, we can have access to these people who live in small villages in the middle of the mountain, very few people. So we keep on advancing along these lines, and we can always get better, right? Regardless of how old we are. And we have some old facilities as well. Some of us also are not digital natives, and it causes stress to most of us. The use of technology continuously, such as we've done in this pandemic, the period of pandemic, has caused a lot of stress. Even before the pandemics, we have planned to develop some actions resulted from a professional dialogue forum that we got together to discuss, and within them there was the priority of increasing digital competences of professionals. Even though we have all clinical histories interconnected and digitalized in Catalonia, and everyone has get adapted to its digital life, there are still some aspects which can be improved in terms of use of information technology and communication. Concerning what Adriana said about the regulation law of healthcare professions, it was a challenge, yes, but we know that the reality tends to be faster than laws. So the law, which is from 1986, we would be ready to change it because social workers were not included in the law. So we have, of course, to fully integrate them as healthcare professionals. So it does require some adjustment. We have a system of control. No cases are going to leave some indicators. The regions where we have some centers, because of that, if you do not meet the quality indicators, the so-called system will determine fewer number of residents or produce no residents until you improve your quality indicators. And this is done in parallel. So quality indicators plus a research that is done every year with students to have information about the hospital and the individual resident physician. And by doing that, we can have a triangulation. I think this is really important because it gives us a unique perspective, and there are more players with whom we are working, and it provides to hospitals and to centers, and they can deal with their improvement margins. I think it's a very good system. And the role of a universal healthcare system is really important. It's a reference because anyone can join this system. It is not based on other issues of social class. It is just an objective test. Anyone who has graduated have access to that, and the ones who have a best performance will be entitled to the seat. It's a very fair system of distribution of resident seats. And I think my time's up, right? Just to conclude, in our systems, we have two very good systems, education and broader system, providing better integration of research in the curriculum, and also improvement of integration of technology at large in a much more humanized fashion, working with transversal competences and focusing on professional values. These would be the most relevant issues, in my opinion. Well, with that, we are getting to the end of our meeting on healthcare in Spain and its model of education, training, and professional capacity building. On behalf of Forum on Innovation on Health, I would like to thank Professor Montserrat for her participation, giving us an excellent presentation and comments, to Professor Adriana Aguiar, whom I would like to thank for the important contributions, and also for the Dean, Denise Carvalho, who unfortunately had to leave before. But I would like to thank you all for your excellent participations. Thanks everyone very much for your participation, and with that we close now. Thank you.
Muchas gracias.
Thank you very much. Thank you. Have a good afternoon. Thank you.